Welcome. In this session, we will be discussing about proliferative diabetic retinopathy. Proliferative diabetic retinopathy or PDR is characterized by the growth of newly formed retinal blood vessels on the retina and or the optic disc growing anterior to and along the surface of the retina and on the posterior vitreous cortex. In this photograph, we see new vessels growing on the retina. PDR is a major cause of severe visual loss in developed countries. The Wisconsin Epidemiologic Study of Diabetic Retinopathy or WESDR was a population-based study evaluating the prevalence of different forms of diabetic retinopathy, which we had discussed in an earlier session. The WESDR found that prevalence of proliferative diabetic retinopathy depended on whether the patient was taking insulin at the time of evaluation, the age at diagnosis of diabetes mellitus, and the duration of diabetes at the time of evaluation. The WESDR found that in insulin-taking patients with age at diagnosis of DM below 30 years, that is the typical type 1 DM patients, had a low prevalence of proliferative diabetic retinopathy in the first 10 years of diabetes mellitus, but the prevalence of proliferative diabetic retinopathy in these patients then increased rapidly, so that two-thirds of these patients had proliferative diabetic retinopathy after 35 years of diabetes mellitus. But in non-insulin taking patients with age at diagnosis of diabetes mellitus 30 years or more, that is the typical type 2 DM patients, the prevalence of proliferative diabetic retinopathy increased only slightly from less than 5% before 20 years of diabetes to 5% thereafter. But because older onset diabetes mellitus was 8 to 10 times more common than younger onset diabetes mellitus, PDR patients in the population were equally likely to have younger onset diabetes mellitus or older onset diabetes mellitus. WESDR found no difference in severity of PDR between younger onset and older onset diabetes mellitus patients. And as with non-proliferative diabetic retinopathy, prevalence of macular edema in eyes with proliferative diabetic retinopathy was more in older onset diabetes mellitus group as compared to younger onset diabetes mellitus group. On the other hand, the diabetic retinopathy vitrectomy study or DRVS found that severity of PDR was less in type 2 DM patients as compared to type 1 DM patients. And the diabetic retinopathy study or DRS found that 44% of PDR patients had an onset of diabetes mellitus before 20 years of age, and the remainder had diabetes mellitus onset at or after 20 years of age. DRS, WESDR, ETDRS, DRVS, and Protocol S are landmark clinical trials in diabetic retinopathy, particularly proliferative diabetic retinopathy. Interestingly, although some diabetic retinopathy do occur in all DM patients given enough time, PDR does not occur in all patients. And one study found that even after 50 years of diabetes, only 50% of patients develop proliferative diabetic retinopathy. And the study observed that worsening of diabetic retinopathy occurs almost entirely in the initial 2 decades of diabetes mellitus. And one candidate protective agent is retinol binding protein 3, which is expressed in larger quantities in the retina and vitreous of eyes which do not develop PDR long term. We have discussed about RBP3 in an earlier session, and RBP3 is known to inhibit GLUT1 glucose transporter and VEGF receptor 2. The DCCT, UKPDS and ACOT trials showed the benefit of glycemia control in reducing the rate of retinopathy progression, and we have discussed these trials in detail in an earlier session. The early treatment of diabetic retinopathy study or ETDRS found that among patients with severe NPDR and early PDR, 5-year risk of developing high-risk PDR was higher in patients with HbA1c level more than 12% as compared to those having HbA1c level less than 8.3%. We'll be defining high-risk PDR, a very important term for the management of PDR, later in this session. Also, early worsening of retinopathy is known to occur in the initial 3 to 12 months following initiation of intensive glycemic control with insulin, and this can lead to severe retinopathy in eyes with advanced retinopathy and very poor glycemic control at baseline. In these eyes, close ophthalmological follow-up after initiating intensive glycemic control is recommended, and panretinal photocoagulation should be considered in these eyes if they have severe NPDR or PDR along with poor glycemic control at baseline. But withholding intensive glycemic control to prevent worsening of diabetic retinopathy in such a situation is not recommended because the worsening of retinopathy is only temporary. Severity of existing diabetic retinopathy also determines the future risk of developing proliferative diabetic retinopathy because severe NPDR is associated with extensive capillary closure, which also increases the risk of developing proliferative diabetic retinopathy. The ETDRS found that the risk of conversion of severe NPDR to high-risk PDR was 15% at 1 year and 60% at 3 years, and also the risk of conversion of very severe NPDR to high-risk PDR was 45% within 1 year. Extent of capillary closure on fluorescein angiography, as seen here in these two photographs, has been correlated with severity of neovascularization, and the severity of neovascularization has been thus classified into the following steps. First, new vessels usually appear on the retina but sparing the disc, and then new vessels appear on the disc, and finally new vessels can appear in the anterior segment. Serial fluorescein angiography examinations have demonstrated that some intraretinal microvascular abnormalities are actually intraretinal new vessels. Sometimes new vessels of PDR may be detected in eyes with less severe NPDR lesions, and this is said to be due to the transient nature of NPDR lesions or due to extensive capillary non-perfusion, which may lead to a featureless retina, which we have discussed in the previous session. Other risk factors of proliferative diabetic retinopathy include dyslipidemia, particularly increased serum triglyceride, and fenofibrates have been found to reduce retinopathy progression in the Accord and Field trials, which we have discussed in an earlier session. Other risk factors of proliferative diabetic retinopathy include diabetic neuropathy, low serum albumin, decreased hematocrit, and hypertension. As we have discussed in an earlier session, hyperglycemia induces capillary closure by various mechanisms, and capillary closure leads to relative retinal ischemia, and this ischemic retina produces various angiogenic factors, among which vascular endothelial growth factor or VEGF is the principal angiogenic factor. Significantly higher levels of VEGF has been detected in eyes with active proliferative diabetic retinopathy, and these high levels of VEGF has been shown to decrease following panretinal photocoagulation, and retinal and iris new vessels respond promptly to anti-VEGF injections, often starting to regress within 1 day of anti-VEGF injection. New vessels typically arise from retinal veins and nearly always grow towards and into areas of retinal ischemia. They then cross the internal limiting membrane and continue to grow along the posterior vitreous cortex by using the posterior vitreous cortex as a scaffold. The newly formed blood vessels are initially primarily vascular but later develop increased amounts of fibrous tissue, as shown in yellow color in this diagram. This fibrous tissue contracts and the posterior vitreous cortex detaches from the retina, except at the site of vitreoretinal adhesion, where the new vessel passes from the retina onto the posterior vitreous cortex. Posterior vitreous detachment and fibrous tissue contraction lead to the two main causes of severe visual loss in proliferative diabetic retinopathy: vitreous hemorrhage and tractional retinal detachment, and this is very important to remember. After a certain period of time, the newly formed blood vessels regress, leaving behind the fibrovascular tissue tethered to the posterior vitreous cortex. Completion of posterior vitreous detachment, either spontaneously or following successful vitrectomy with lysis of these vitreoretinal adhesions, is followed by regression and decreased recurrence of new vessels on the surface of the retina. And panretinal photocoagulation and anti-VEGF injections, which we will be discussing further in this session, induce early involution of these new blood vessels. Well-developed new vessels typically form a network appearing as a part or all of a carriage wheel, as seen here in this photograph. The vessels appear to radiate from a central vessel in the network and connect with a circumferential vessel. The new vessel networks are often found lying anterior to a retinal vein. New vessels may also appear irregular without forming a network, and this pattern is often found over the optic disc as seen here in this photograph. When this pattern of new vessels occur over the retina, the new vessels can be differentiated from normal retinal vessels by the ability of these new vessels to cross over both retinal arteries and retinal veins, which normal retinal vessels do not. Very early new vessels are bared as seen here in this photograph. Later they develop fibrous tissue, and the fibrous tissue may be initially translucent but later becomes opaque. In a neovascular network, fibrosis and regression start in the center of the network, and fresh new vessels arise from the edges of a partially regressed neovascular network as seen here in this photograph. When the posterior vitreous remains attached to the retina, the neovascular patch growing on the anterior surface of the retina become adherent to the posterior vitreous cortex, and this is probably the most important statement in this session. Prior to posterior vitreous detachment, the neovascular patch may appear slightly convex as the center of the patch is slightly elevated and the edges of the patch remain adherent to the retina. Small pre-retinal hemorrhages may be present adjacent to the neovascular patch, but prior to PVD occurring adjacent to the neovascular patch, the patient remains asymptomatic. We'll be discussing what happens after posterior vitreous detachment later. Diabetic retinopathy study, or DRS, describes the distribution of new vessels in eyes with proliferative diabetic retinopathy. 15% of eyes in DRS had neovascularization on disc, which is defined as neovascularization within one disc diameter of the center of the optic disc. 40% of eyes had neovascularization elsewhere, or NVE, and 45% of eyes had both NVD and NVE. The DRS found that the most common location of NVE was superotemporal quadrant of the retina, followed by the inferotemporal quadrant. New vessels are easily overlooked in their early stages, particularly with low magnification of binocular indirect ophthalmoscopy, and non-stereoscopic examination of the fundus may also be unable to differentiate between new vessels and normal vasculature. New vessels are best detected clinically with magnified stereoscopic examination by slit lamp biomicroscopy or standard stereoscopic photographs. For detecting new vessels by slit lamp biomicroscopy, the Goldmann contact lens is said to be the best, but non-contact fundus lenses are more commonly used because of their convenience. And when new vessels are suspected because of a recent vitreous hemorrhage but not readily clinically detectable, the area 5 to 6 disc diameter from the optic disc should first be searched, and if new vessels are not found in this area in the posterior pole, the peripheral retina should be searched by slit lamp biomicroscopy with a Goldmann contact lens. And it is important to remember that other causes of vitreous hemorrhage, such as a retinal tear, must be excluded. Fluorescein angiography is very useful to detect suspected but clinically undetected neovascularization, and new vessels show profuse leakage of fluorescein dye as seen here in this photograph. Ultrawide field imaging, as seen here in this photograph, covers more than 80% of the retina in a single image, in contrast to the 7 standard ETDRS photographs, which cover only 30% of the retina when combined together. Protocol AA of DRCR found that patients with predominantly peripheral diabetic retinopathy lesions on ultrawide field fluorescein angiography had a higher risk of progression of diabetic retinopathy as compared to patients who do not have predominantly peripheral lesions of diabetic retinopathy. Predominantly peripheral lesions of diabetic retinopathy is defined as presence of greater extent of diabetic retinopathy lesions outside the 7 standard ETDRS fields as compared to within the 7 standard ETDRS fields. This ultrawide field fluorescein angiogram shows multiple areas of capillary occlusion along with multiple neovascular patches profusely leaking fluorescein dye. Octa can also detect new vessels as seen here in this photograph. Differentiating new vessels from armors is important, and unlike armors, well-developed new vessels appear as wheel-like networks, cross over both underlying retinal arteries and veins, and have associated fibrous tissue. But it is important to note that early new vessels may not demonstrate all of these features. But as we have discussed, fluorescent angiography shows profuse leakage of fluorescent dye from new vessels, but fluorescent leakage from armors is either less or absent. Posterior vitreous detachment or PVD is a major pathogenic mechanism of proliferative diabetic retinopathy, and as we have discussed, it initiates and extends from the location of the neovascular patch. This is because of the contraction of the fibrous neovascular tissue adherent to the posterior vitreous cortex, and also from the contraction of the posterior vitreous cortex itself. PVD usually begins in the region of the supratemporal blood vessels, where NVE occurs most frequently. PVD may be clinically detected by the presence of strands and opacities anterior to the detached posterior vitreous cortex, while the space posterior to the detached posterior vitreous cortex remains optically clear. And sometimes the posterior vitreous cortex appears as a semi-opaque sheet with round and oval cleared areas. PVD does not extend and complete in a smoothly progressing process. PVD progresses in abrupt steps, getting halted when the progressing PVD reaches another neovascular patch, either active or regressed, or a normal vitreoretinal adhesion. The PVD ultimately extends further peripherally, but may take months to years to entirely complete. And following completion of PVD, new vessels on the surface of the retina become less active as they lack the scaffold of posterior vitreous cortex to grow. And it is important to remember that if tractional retinal detachment does not occur prior to occurrence of PVD, tractional retinal detachment does not occur after the completion of PVD. Following the initiation of PVD, the posterior vitreous cortex pulls the edges of the neovascular patch forward, making the neovascular patch appear slightly concave. With a localized PVD around the neovascular patch, pre-retinal hemorrhages appear small with the anterior surface parallel to the retina, but when PVD becomes extensive, the blood can reach the vitreous cavity. Vitreous and/or pre-retinal hemorrhage in proliferative diabetic retinopathy usually occur due to traction on the new vessels and usually coincides with extension of posterior vitreous detachment, which occur in abrupt steps, and so vitreous and/or pre-retinal hemorrhage are often recurrent in proliferative diabetic retinopathy. Most vitreous and/or pre-retinal hemorrhages have been observed to occur during sleep, but vitreous and/or pre-retinal hemorrhages may occasionally occur from Valsalva maneuvers, active exertion, head trauma, and insulin reactions. But restricting physical exercises in a patient with VH or active PDR is not indicated. Vitreous hemorrhage occurs in form vitreous, slowly loses its red color and becomes grayish in color over time and takes many months for absorption, and at times vitreous hemorrhage does not completely disappear even after a prolonged period of time. Pre-retinal hemorrhage, which can be either subhyaloid, that is between the posterior vitreous cortex and the retina, or sub-internal limiting membrane, that is between the internal limiting membrane and the remainder of the retina, are absorbed relatively quickly within weeks to months and remain red in color till absorption. In the macula and the inferior quadrant, pre-retinal hemorrhages pool in the retrohyaloid space and usually demonstrate a flat top, as seen here in this clinical photograph, and an inferior curved edge occurring along the junction of attached and detached posterior vitreous cortex, and the shape of pre-retinal hemorrhages is called boat-shaped pre-retinal hemorrhage. Minimal pre-retinal hemorrhage with extensive PVD may appear as a thin curving streak of blood in the inferior quadrant, as seen here in this photograph, which also occurs along the junction of attached and detached posterior vitreous cortex, and this thin curving streak of blood appears to be posterior and parallel to the equator. And a tight sub-ILM hemorrhage can rapidly progress to tractional retinal detachment. In the superior quadrant, pre-retinal hemorrhages often appear as meridional streaks of blood adherent to the detached posterior vitreous cortex. In eyes with vitreous hemorrhage precluding ophthalmoscopy, B-scan ultrasonography should be periodically performed till surgery or spontaneous resolution of vitreous hemorrhage to detect the occurrence of any retinal detachment and evaluate its configuration. Retinal displacement in proliferative diabetic retinopathy can be in the form of macular distortion, tractional retinal detachment, combined rhegmatogenous and tractional retinal detachment, and also in the form of retinoschisis. As we have discussed earlier, retinal displacement in proliferative diabetic retinopathy occurs from contraction of the posterior vitreous cortex and contraction of the fibrovascular proliferation growing over the posterior vitreous cortex if the fibrovascular proliferation remains adherent to the retina, and this adhesion is called vitreoretinal adhesion. And as we have discussed, TRD does not occur following complete detachment of the posterior vitreous cortex. Macular distortion tends to progress nasally as most extensive fibrovascular proliferation occurs around the disc. Tractional retinal detachment usually occurs in the posterior pole and can appear as an elevation of a fold of retina if there is only a localized vitreoretinal adhesion, or as an elevation of a broad region of retina if the vitreoretinal adhesion is extensive, and this type of tractional retinal detachment is called tabletop tractional retinal detachment. Tractional retinal detachment usually have a smooth concave surface and appears taut with no movement with ocular rotations. Tractional retinal detachment is uncommon in eyes with new vessels localized to the optic disc, but these eyes with NVD can still have recurrent vitreous hemorrhage, and only occasionally a tractional retinal detachment may disappear spontaneously. Combined tractional and rhegmatogenous retinal detachment, as seen here in this photograph, occur when full thickness retinal holes develop within the tractionally detached retina, and these full thickness retinal holes occur from the traction itself, and these holes are usually oval in shape and are found particularly near the vitreoretinal adhesions in the posterior pole. Unlike tractional retinal detachment, combined tractional and rhegmatogenous retinal detachments appear to be more extensive, usually extending up to the ora serrata, are flat or convex anteriorly with a dull corrugated and undulating surface. So the retinal break or hole usually occurs in the region of the TRD due to the vitreoretinal adhesion itself, and when fluid vitreous migrates through this retinal hole into the subretinal space, the concave configuration of TRD changes to the convex configuration of combined tractional and rhegmatogenous retinal detachment. The retinal holes of combined tractional and rhegmatogenous retinal detachment, as seen here in this clinical photograph, are often difficult to detect clinically because of the associated vitreous hemorrhage and fibrous tissue. Other than macular distortion, tractional retinal detachment and combined tractional and rhegmatogenous retinal detachment, retinoschisis may also occur from traction due to vitreoretinal adhesion. Involutional PDR, also known as burnt out or quiescent PDR, is the final stage in the natural history of PDR. We described a similar entity called featureless retina in the end stage of NPDR. In involutional PDR, separation of the posterior vitreous cortex from the retina is complete except at sites of vitreoretinal adhesions. The new vessels decrease in number and caliber, and the fibrous tissue associated with the new vessels may become thinner and more transparent, as seen in this eye, as compared to its previous photograph taken 7 years earlier. Vitreous hemorrhage becomes less frequent and finally occurs no longer, and retinal detachment, which has already occurred, may still persist. Hemorrhages and microaneurysms become scant, and beading and dilatation of retinal venules decrease, along with a decrease in the number of tributaries of retinal veins, and retinal veins and arteries may appear sheathed or as white threads, as seen here in this clinical photograph. Loss of vision in involutional PDR can be due to macular dragging or macular detachment, macular ischemia, and chronic macular edema. Management of proliferative diabetic retinopathy has two principal aims. One is to prevent progression and induce regression of proliferating new vessels, and the other is to relieve the effects of contracting posterior vitreous cortex and fibrovascular proliferations on the retina. Before the advent of panretinal photocoagulation and anti-VEGF injections, anterior hypophyseectomy was a treatment option for proliferative diabetic retinopathy, and this was said to occur by decreasing growth factor levels in the body, but this procedure is now of historical interest only. Laser photocoagulation has become the standard treatment for proliferative diabetic retinopathy, and xenon arc photocoagulation was the initial laser procedure developed for proliferative diabetic retinopathy, but this procedure is no longer performed because of increased incidence of adverse effects with xenon arc photocoagulation as compared to other methods of laser photocoagulation. Panretinal photocoagulation involves treatment of the entire retina between the posterior pole and the mid-periphery, and it is based on the observation of significant asymmetry of severity of diabetic retinopathy between the two eyes of patients with unilateral diffuse chorioretinal scarring, where it has been observed that the eye with chorioretinal scarring had less severe retinopathy. Panretinal photocoagulation is said to induce regression of existing new vessels and prevent development of fresh new vessels by reducing VEGF production from ischemic retina by the following proposed mechanisms: by ablating ischemic retina, by increasing intraocular oxygen levels as oxygen from choroid passes easily through the thin retina at the site of laser scars, and by redistribution of blood supply and oxygen to the remaining retina. Diabetic retinopathy study, or DRS, is one of the earliest studies which is still relevant in clinical practice. DRS evaluated the efficacy of panretinal photocoagulation with either argon laser or xenon arc laser in eyes with severe NPDR and PDR in reducing the incidence of severe visual loss defined as visual acuity of 5/200 or less, and patients were randomized to argon laser or xenon arc PRP with one eye randomized to treatment and the other eye being observed. DRS divided the patients into 9 subgroups with different severity of DR lesions to evaluate the efficacy of PRP in each of the subgroups, and at 2 years DRS found that there was more than 50% reduction in the incidence of severe visual loss in almost all subgroups. But this effect became apparent earlier and was more prominent in eyes with more severe PDR, particularly in eyes with certain characteristics which were defined by DRS as high-risk characteristics of PDR. And high-risk characteristic PDR is the presence of any one or more of neovascularization of disc 1/4 to 1/3 in disc area or more in size, neovascularization of the disc of any size associated with fresh vitreous or pre-retinal hemorrhage, and neovascularization elsewhere greater than or equal to 1/2 disc area associated with fresh vitreous or pre-retinal hemorrhage. This table shows the DRS data at 2 years and 4 years as regards severe visual loss in the treated group and the control group, and the 9 subgroups have been regrouped into 3 groups: severe NPDR, PDR without HRC, and PDR with HRC. And we find that the difference in the incidence of severe visual loss between the two groups is the maximum in eyes with PDR with high risk characteristics at baseline. So we note here the very high risk of severe visual loss in eyes with PDR with high risk characteristics. And DRS also observed that decline of visual acuity due to PRP frequently occurred in the initial several weeks, but most eyes recovered. But 30% of eyes receiving xenon arc PRP did not recover visual acuity as compared to 14% of eyes treated with argon laser, and because of this PRP with xenon arc has been abandoned. Considering the risk-benefit ratio of PRP, DRS strongly recommended prompt PRP to reduce the risk of severe visual loss in eyes with high-risk characteristic proliferative diabetic retinopathy, and this is very important to remember. And in eyes with severe NPDR or non-high-risk characteristic PDR, either prompt PRP or observation was acceptable, but eyes being observed should be closely followed up and should receive prompt PRP when high-risk characteristics develop on follow-up. We have discussed about early treatment of diabetic retinopathy study, or ETDRS, in the session on non-proliferative diabetic retinopathy, and one aim of the study was to evaluate the efficacy of immediate PRP versus deferred PRP till HRC-PDR develops in eyes with mild to severe NPDR or early, that is non-high-risk characteristic PDR. The outcome measure was the first occurrence of severe visual loss or need for vitrectomy. Eyes randomized to immediate PRP group were further randomized to receive any one of 2 patterns of treatment. Full scatter consisted of 1200 to 1600 burns, whereas mild scatter consisted of 400 to 650 burns. And although ETDRS found that the 5-year incidence of severe visual loss or vitrectomy was higher in the deferred laser group as compared to that in the immediate laser group, The incidences of these events were low in eyes with NPDR and even in eyes with non-high-risk characteristic PDR. ETDRS recommended that PRP should be deferred in eyes with mild to moderate, that is non-high-risk characteristic PDR, but PRP is recommended in these eyes if severe visual loss occurred in the fellow eye from proliferative diabetic retinopathy, frequent follow-up cannot be ensured, and certain comorbidities exist which accelerate retinopathy progression, such as pregnancy, renal failure, and very poor glycemic control. But prompt PRP should be done whenever high-risk characteristic PDR is detected in these patients on follow-up, as was recommended by diabetic retinopathy study, and this is very important to remember. Later subgroup analysis of ETDRS data showed that among patients with severe, very severe NPDR or non-HRC PDR receiving immediate PRP, those with type 2 DM and older than 40 years of age did better at 5-year follow-up as compared to patients in the deferred PRP group. Current indications of panretinal photocoagulation include proliferative diabetic retinopathy with high-risk characteristics, severe, very severe NPDR and non-HRC PDR if follow-up is uncertain, if comorbidities exist which are likely to accelerate retinopathy progression, and if the patient has had a poor outcome from PDR in the fellow eye, and also in eyes with anterior segment neovascularization even if HRC PDR is not present in the posterior segment. Following initial PRP, new vessels usually regress within days to weeks, and signs of regression include decrease in caliber of new vessels and development of fibrous tissue. Regression is complete in approximately 2/3 of patients after initial completion of PRP, and the response is more favorable in type 2 DM patients as compared to type 1 DM patients. Indication for repeat PRP after initial PRP include recurrent vitreous and or pre-retinal hemorrhage and actively growing new vessels, which usually appear to have a tighter network, lack associated fibrous tissue, and in comparison to previous visits are not decreased in caliber and appear to be more extensive. The current protocol of initial PRP is as follows. The power setting is adjusted so as to obtain mild white retinal burns, and the intensity of the retinal burns depend on pigmentation of the fundus and the size and duration of the spots. The target size of the spots is 500 micron, and since Goldman 3-mirror lens does not produce any magnification with the Goldman 3-mirror lens, the spot size setting on the machine is 500 microns. But with the other lenses which produce magnification to obtain 400 to 500 micron retinal burns, the spot size setting on the machine has to be 200 microns. The duration setting of the spots is usually 100 milliseconds for PRP, and the separation of the spots on the retina is usually 1 burn width. The location of burns placed in PRP are as follows: superiorly and inferiorly from the temporal arcades up to the equator, and 1 row of burn can be placed central to the temporal arcades. Temporally, the burns are placed 3000 microns, that is 2 disc diameters, from the center of the fovea and then extending peripherally from there. And nasally, burns are placed 500 micron from the optic disc and then extending peripherally from there. Number of spots applied is 1200 to 1600 spots in total. The total number of sittings can vary from 1 to 4. If 3 or more sittings are planned, the sittings are spaced at 4-day intervals, and if 2 sittings are planned, the sittings are spaced at 2-week interval. DRCR Protocol F found increased thickening of macula and decrease in visual acuity with 1 sitting PRP as compared to 4 sitting PRP at 3 days and 4 weeks of initiation of PRP, which reversed at 34 weeks without any long-term differences. When repeat PRP is required, burns are placed in areas of retina where scars of previous PRP have wide separation or are absent, and if scars of initial PRP are adequately spaced and covers all accessible areas of retina, repeat PRP is less beneficial and is not indicated as it increases visual defects and nyctalopia. In such a situation, alternatives to PRP should be considered, which include anti-VEGF injections and vitrectomy with laser photocoagulation of pre-equatorial retina. The wavelengths used for PRP are commonly either green lasers or infrared lasers. Green lasers include argon laser and frequency doubled Nd:YAG laser, and the wavelengths of these lasers are absorbed by melanin in RPE and by hemoglobin to produce the desired effect of photocoagulation. Argon lasers are gas lasers and so have cumbersome equipment, while frequency doubled Nd:YAG lasers are solid state lasers and so are the commonly used green lasers. Infrared lasers such as diode lasers can also be used for PRP, and the diode laser wavelength is absorbed by melanin in RPE, and since the diode laser wavelength is longer, it can penetrate deeper into the retina and choroid and can also penetrate more efficiently through hemorrhages. Like frequency doubled Nd:YAG lasers, diode lasers are also solid state lasers and so are commonly used for PRP. Pattern or multi-spot lasers such as Pascal and Navilas deliver multiple spots in various patterns as seen here in this photograph with a single foot pedal application. These are based on frequency doubled Nd:YAG lasers, but some studies suggest higher incidence of recurrent neovascularization and need for additional PRP in patients undergoing treatment with pattern or multi-spot laser as compared with patients undergoing treatment with conventional PRP. Adverse effects of PRP are very important to remember, and they include loss of visual function such as visual field defects, loss of dark adaptation, nyctalopia, and impairment of color vision and contrast sensitivity. Application of PRP is known to induce further contraction of existing fibrous proliferation as seen here in these two photographs due to regression of new vessels on posterior vitreous cortex causing TRD and vitreous or pre-retinal hemorrhages. And areas of fibrous proliferation and TRD and excessively intense burns in this situation should be avoided during PRP. Even then, fibrous proliferation should not contraindicate PRP in high-risk characteristic PDR. Direct damage in the form of inadvertent foveal or optic disc damage, retinal tear, Bruch membrane rupture leading to choroidal hemorrhage and choroidal neovascularization, and iris and lenticular burns can occur during panretinal photocoagulation. PRP can also induce damage to blood-retina barrier leading to macular edema and choroidal effusions. Macular edema may lead to transient and sometimes permanent decline in visual acuity, and in ETDRS, 18% of patients who had less severe retinopathy without CI-DME at baseline developed CI-DME at 4 months following PRP, and DRS found that among eyes with DME at baseline, a larger proportion of treated eyes as compared to untreated eyes had decrease in visual acuity at 6 weeks from baseline. On the other hand, among eyes without DME at baseline, a smaller proportion of treated eyes had a decrease in visual acuity at 6 weeks after PRP as compared to eyes with DME at baseline, but this proportion was still higher than untreated eyes without DME at baseline. And among eyes with DME at baseline, the difference in the proportion of patients having decrease in visual acuity among the treated and untreated eyes at 6 weeks disappeared at 1 year from baseline. PRP-induced disturbance in blood-retinal barrier may also lead to choroidal effusions and or exudative retinal detachment, which may lead to angle closure, and this is more likely to occur if full PRP is performed in one sitting. Iritis can also occur following PRP because of PRP-induced damage to blood-retina barrier. Other adverse effects of PRP include pain, corneal erosions, and mydriasis and or accommodation paralysis. To reduce the risk of adverse effects of PRP, the following are recommended: careful noting of landmarks central to which PRP should not be done, adequate pupillary dilatation to avoid lens or iris burns, avoiding the horizontal meridian along which the long ciliary nerves pass anteriorly decrease pain and reduces the risk of mydriasis, accommodation palsy, and loss of corneal sensitivity after PRP. Carefully titrating burn intensity and shortening exposure time may reduce pain, but rarely local anesthesia may be required in some patients to complete PRP. Avoiding intense small burn reduces the risk of Bruch membrane rupture, and adequate use of coupling fluid and gentle maneuvering of contact lens decrease the risk of corneal erosions. Intravitreal anti-VEGF therapy induces rapid and extensive regression of new vessels, but unlike PRP, the effect of anti-VEGF therapy is short-lived. Protocol S of DRCR evaluated the efficacy of intravitreal ranibizumab versus PRP in eyes with PDR over 2 years. The ranibizumab group received 0.5 mg ranibizumab every 4 weeks till week 12, and therapy was continued until stabilization or regression of all new vessels. Ranibizumab was repeated if there was a recurrence of new vessels, and PRP could be done in cases of treatment failure with ranibizumab. Patients in the PRP group received full scatter at baseline in 1 to 3 sittings, and in this group PRP could be repeated if required, and both groups were eligible for ranibizumab injections for DME and vitrectomy for VH and TRD. A total of 394 eyes were included in this study. The study concluded that at 2 years, efficacy of ranibizumab was non-inferior to PRP as regards mean visual acuity loss, but the ranibizumab group showed better visual acuity gain, lower reduction in peripheral retinal sensitivity on visual field testing, lower incidence of diabetic macular edema, and lower need for vitrectomy. But in the subgroup of eyes with regressed new vessels or without active new vessels, the effect was not significantly different between the ranibizumab group and the PRP group, and no difference in serious systemic adverse effects between the two groups were observed. The ranibizumab group required a median of 10 to 14 injections over 2 years, and 6% of eyes in the ranibizumab group required PRP, and 4% of eyes in this group required vitrectomy. 45% of eyes in the PRP group required repeat PRP at a median interval of 7 months, and in this group 35% of patients required ranibizumab for DME at baseline, and 18% of eyes required ranibizumab for DME during follow-up. DR worsening, defined as first occurrence of vitreous hemorrhage, tractional retinal detachment, or neovascular glaucoma in 2 years, was higher in the PRP group as compared to the ranibizumab group. PDR worsening was more in eyes with baseline HRC PDR or worse as compared with eyes with moderate PDR or better, and also in eyes receiving pattern or multispot laser PRP as compared to eyes receiving PRP with conventional lasers. The Protocol S study was continued till 5 years, and 66% of eyes completed 5 years of follow-up. Visual acuity results were found to be excellent and similar in the two groups at 5 years, with mean visual acuity of 20/25 in both groups, and even at 5 years, ranibizumab group had a lower incidence of vision-threatening DME and less peripheral visual field loss. And this was the data over 5 years regarding the number of repeat treatments in both the groups. Protocol N of DRCR evaluated the effect of intravitreal ranibizumab versus intravitreal saline in eyes with vitreous hemorrhage from proliferative diabetic retinopathy, which precluded panretinal photocoagulation on the main outcome measure of rates of vitrectomy within 16 weeks, and the study found no significant difference in the rates of vitrectomy between the ranibizumab and saline groups. Clarity study compared the efficacy of intravitreal aflibercept versus standard PRP in patients with proliferative diabetic retinopathy without macular edema over a period of 52 weeks. The Clarity concluded that at an additional cost, intravitreal aflibercept was both non-inferior and superior to panretinal photocoagulation in the first year of treatment. Current recommendations for anti-VEGF therapy in proliferative diabetic retinopathy are as follows. Treatment initiation with anti-VEGF is recommended in PDR eyes with diabetic macular edema, and in these eyes, panretinal photocoagulation, which is known to worsen diabetic macular edema, can usually be deferred till diabetic macular edema resolves. In PDR eyes without diabetic macular edema, anti-VEGF injections and PRP are equally effective options, but cost, number of visits, ability to follow up should be considered while deciding between these two treatments. Anti-VEGF injection is also now recommended for neovascular glaucoma when panretinal photocoagulation is not possible in these eyes, and anti-VEGF can be used as an adjunct to vitrectomy to induce regression of new vessels prior to surgery so as to reduce the incidence of intraoperative hemorrhage, but anti-VEGF for this purpose should be administered at or within 7 days of surgery to reduce induction or worsening of tractional retinal detachment. Following anti-VEGF injections, rapid contracture of fibrous tissue can occur associated with regressing new vessels, and this may lead to retinal tears, tractional retinal detachment, and combined tractional and rhegmatogenous retinal detachment, and this is called the crunch phenomena. We have seen that this may also occur following PRP in eyes with fibrovascular proliferation, but following PRP, this contracture of fibrous tissue is much less rapid. Other adverse effects of anti-VEGF include endophthalmitis, cataract, intraocular hemorrhage, and raised intraocular pressure. Many clinicians now combine anti-VEGF with PRP in the treatment of PDR, with the reasoning that anti-VEGF will induce rapid regression of new vessels and prevent or treat existing or PRP-induced macular edema, whereas PRP will produce a durable effect, often for decades, avoiding repeated injections of anti-VEGF over time. When vitrectomy was initially introduced, initial indications of vitrectomy for PDR were vitreous hemorrhage not clearing over 1 year and tractional retinal detachment involving macula. As we have discussed, vitreous hemorrhage and tractional retinal detachment can occur either as part of natural history of PDR or consequent to treatment of PDR with either PRP or anti-VEGFs. Goals of vitrectomy in PDR include clearing of ocular media, relieving anteroposterior and tangential traction on the retina from posterior vitreous cortex and fibrovascular proliferation, and performing thorough panretinal photocoagulation intraoperatively. Tangential traction, as shown here in this diagram, can be relieved by either delamination or segmentation. In delamination, the fibrovascular proliferation is separated from the detached retina, and in segmentation, the fibrovascular proliferation between two adjacent vitreoretinal adhesions is incised. Diabetic Retinopathy Vitrectomy Study, or DRVS, had 3 study arms. One was to evaluate the natural history of PDR, the second was to evaluate the efficacy of early versus delayed vitrectomy in eyes with advanced active PDR but without severe vision loss, and the third was to evaluate the efficacy of early versus delayed vitrectomy in eyes with PDR and recent onset vitreous hemorrhage causing severe visual loss for at least 1 month. Early vitrectomy was defined as vitrectomy performed within 1 to 6 months of clinical presentation or symptom onset, and delayed vitrectomy was defined as vitrectomy performed after 12 months or more following clinical presentation or symptom onset. DRVS found beneficial effects of early vitrectomy in eyes with severe visual loss from non-clearing vitreous hemorrhage of more than 1 month's duration, which was published in DRVS Report 1, and this effect was particularly prominent in type 1 diabetes mellitus as compared to type 2 diabetes mellitus, and also irrespective of type of diabetes mellitus, early vitrectomy was beneficial in monocular patients with non-clearing vitreous hemorrhage by prompt restoration of visual function. Early vitrectomy was also found to be beneficial in eyes with advanced active PDR but without severe visual loss, particularly when extensive new vessels were present, and this was published in DRVS report number 3. DRVS also reported the incidence of no light perception vision in eyes undergoing vitrectomy and found that the incidence in the vitreous hemorrhage arm of the study was 20% in both the early and late vitrectomy groups, but the incidence of NLP in the advanced active PDR arm of the study was higher in the early vitrectomy group as compared to the delayed vitrectomy group. So DRVS recommended early vitrectomy for non-clearing vitreous hemorrhage of at least 1 month duration, but for advanced active proliferative diabetic retinopathy without severe visual loss, DRVS did not recommend early vitrectomy as an alternative to panretinal photocoagulation, but suggested it as an adjunct when new vessels do not regress adequately or complete PRP is not possible. And this is very important to remember. Protocol AB of DRCR compared the efficacy of initial intravitreal aflibercept injection versus vitrectomy combined with panretinal photocoagulation in eyes with vitreous hemorrhage from PDR. Protocol AB concluded that there was no significant difference in visual acuity outcomes both at 24 weeks and at 2 years from baseline, but eyes assigned to vitrectomy had faster visual recovery and greater clearance of vitreous hemorrhage at 4 weeks from baseline and were also less likely to have recurrent vitreous hemorrhage and active new vessels over the 2-year study period. And eyes assigned to affluent subgroup were less likely to have centered involving diabetic macular edema. Current indications of vitrectomy for proliferative diabetic retinopathy are as follows: to improve visualization of retina, to complete panretinal photocoagulation in eyes with severe non-clearing vitreous hemorrhage, dense subhyaloid hemorrhage, and anterior segment neovascularization with media opacity, for immediate visual rehabilitation in patients with bilateral severe vitreous hemorrhage, to relieve vitreoretinal traction causing or threatening visual impairment, and this includes tractional retinal detachment threatening or involving the fovea, combined erythematogenous and tractional retinal detachment, and macular distortion, epiretinal membrane, and opacified posterior vitreous cortex causing visual loss. Macular sparing tractional retinal detachments should be observed instead of being operated, as most do not progress to involve the macula, and these patients should be counseled to report whenever there is a further drop in vision. Vitrectomy is also indicated in PDR to control progressive retinopathy despite adequate PRP, and this includes progressive fibrovascular proliferation, anterior hyaloidal fibrovascular proliferation, and ghost cell and hemolytic glaucoma. Anterior hyaloidal fibrovascular proliferation originates from the anterior region of the vitreous cortex and grows over the anterior hyaloid face to reach the posterior surface of the lens. Anterior hyaloidal fibrovascular proliferation is a particularly poor prognostic factor because it can cause ciliary body detachment leading to hypotony. Following vitrectomy for proliferative diabetic retinopathy, 20 to 35% of patients have decreased vision and 10% of patients require multiple vitrectomies, mainly due to erythematogenous retinal detachment and recurrent vitreous hemorrhages. Prognosis is poorer in patients with tabletop tractional retinal detachment, significant preoperative vitreous hemorrhage, severe fibrovascular proliferation, no prior panretinal photocoagulation, need for lensectomy for anterior hyaloidal proliferation, and occurrence of iatrogenic retinal breaks and occurrence of neovascular glaucoma post-operatively. To recap the salient points, proliferative diabetic retinopathy or PDR is characterized by the development of new blood vessels on the anterior surface of the retina and over the posterior vitreous cortex, to which it becomes tightly adherent. New vessels develop because of production of angiogenic factors, chiefly VEGF, from ischemic retina. Initially, the new vessels are bare, but later they develop fibrous tissue. Contraction of this fibrous tissue and the posterior vitreous cortex lead to the major vision-threatening complications of PDR, namely vitreous hemorrhage and tractional retinal detachment. Proliferative diabetic retinopathy is more common in type 1 DM patients, and the incidence of PDR increases dramatically after 10 years of type 1 DM. On the other hand, only 50% of all diabetes mellitus patients develop proliferative diabetic retinopathy after 50 years of diabetes. In poorly controlled diabetics, initiation of intensive glycemic control often leads to worsening of diabetic retinopathy in the first few months. Diabetic retinopathy study, or DRS, found that 15% of PDR patients had only neovascularization on disc, 40% had only neovascularization elsewhere, and 45% had both NVD and NVE. New vessels can occur in a network appearing like a carriage wheel and can cross both retinal arteries and veins. Fluorescent angiography is very useful to detect suspected but clinically undetected neovascularization. Fluorescent angiography typically shows profuse leakage of dye from new vessels. Posterior vitreous detachment, or PVD, is a major pathogenic mechanism in PDR. PVD usually progresses in abrupt steps from one site of neovascularization adherent to posterior vitreous cortex to the next, pulling on the new vessels and initiating vitreous hemorrhage and tractional retinal detachment. Following complete separation of posterior vitreous cortex from the retina, TRD do not develop. Vitreous hemorrhage occurs within formed vitreous, gradually loses its red color and appears gray, and takes several months to reabsorb. Pre-retinal hemorrhages occur posterior to posterior vitreous cortex, are reabsorbed more quickly within a few months, and remain red in color till reabsorption. The pre-retinal hemorrhages are often board-shaped with a flat top and can occur either in the retrohyaloid or sub-ILM space. In eyes with vitreous hemorrhage being observed, periodic USG-B scans are recommended to detect underlying retinal detachment, which requires surgery. Retinal displacement occurs due to traction from contracting fibrovascular proliferation and posterior vitreous cortex and includes macular distortion, tractional retinal detachment, combined tractional and rhegmatogenous retinal detachment, and retinoschisis. Tractional retinal detachment can occur as folds in the retina or as broad areas of retinal elevation called tabletop TRD. TRD does not occur in eyes with new vessels localized to disc and following complete separation of posterior vitreous cortex from the retina. Combined retinal detachment occur when full thickness retinal holes develop in the area of TRD due to traction from the vitreoretinal adhesions. Involutional PDR is the final stage of PDR where new vessels regress, the associated fibrous tissue becomes more translucent, NPDR lesions regress, and retinal arteries and veins appear sheathed or atrophic. Management of PDR include panretinal photocoagulation, anti-VEGF injection, and vitrectomy. PRP and anti-VEGF injections reduce VEGF levels, causing regression of new vessels. These two modes of therapy may cause significant contraction of fibrous tissue associated with regressing new vessels, resulting in TRD, retinal tears, and combined RD. Diabetic Retinopathy Study or DRS recommended panretinal photocoagulation in proliferative diabetic retinopathy with high-risk characteristics, which is defined as presence of any one or more of neovascularization on disc, 1/4 to 1/3 or more disc area in size, NVD of any size associated with fresh vitreous or pre-retinal hemorrhages, and NV more than 1/2 disc area in size with fresh vitreous or pre-retinal hemorrhages. Early treatment diabetic retinopathy study or ETDRS recommended deferral of panretinal photocoagulation in eyes with severe NPDR and non-HRC PDR and to closely follow up these eyes and initiate PRP when high-risk characteristics develop on follow-up. But eyes with severe NPDR and non-HRC PDR should undergo PRP if the fellow eye had already lost vision from PDR. Follow-up is uncertain and comorbidities exist which may accelerate retinopathy progression. PRP is also indicated in eyes with anterior segment neovascularization even if high-risk characteristics are absent in the posterior segment. In full PRP, approximately 1200 to 1600 burns are placed, spaced one burn width apart, each 500 micron in size and of mild white intensity, and placed in the posterior pole sparing the area 3000 microns from foveal center and 500 microns around the optic disc in 1 to 4 sittings. Lasers commonly used are frequency doubled Nd:YAG laser and diode laser. Adverse effects of PRP include visual field defects and nyctalopia, further contraction of fibrous tissue, worsening of macular edema, choroidal effusions and exudative retinal detachment, choroidal neovascularization, inadvertent foveal or optic disc burns, mydriasis, and loss of accommodation. Protocol S of DRCR found that in comparison to PRP, intravitreal ranibizumab was non-inferior as regards mean visual acuity loss, but eyes receiving ranibizumab had better visual acuity gain, lower incidence of diabetic macular edema, lower incidence of visual field loss, and reduced need for vitrectomy. Anti-VEGFs are indicated as initial therapy in PDR eyes with diabetic macular edema, in eyes with anterior segment neovascularization when PRP is not possible, and as an adjunct to vitrectomy to reduce the incidence of intraoperative hemorrhage. Indications of vitrectomy include non-clearing vitreous hemorrhage of more than 1 month's duration, which was the recommendation by DRVS, bilateral severe VH to rapidly restore visual function, clearing ocular media to complete PRP, tractional retinal detachment threatening or involving fovea, combined rhegmatogenous and tractional retinal detachment, macular distortion, progressive fibrovascular proliferation, anterior hyaloidal proliferation, ghost cell glaucoma, and anterior segment neovascularization when PRP is not possible because of media opacity. Thank you for listening.